Papa kama soka, all the sun wala wala. Somebody says thunder, oh la la. Is it Papa kama soka, all the sun wala wala. Somebody says thunder, oh la la. Well, you see, my friends, I'm touchy, home and midnight. They brought their palava so I can fix it for them. But what I don't understand, why should they make palava for this rascal woman who is called Lala? Is it Papa kama soka, all the sun wala wala? Somebody says thunder, oh Lala. Papa kama soka, all the sun wala wala. Somebody says thunder, oh la la. Peace and whisper and tell me low, it is gonna wet with this phosphor so. So I say whoa, now I know. We go found out who is who. We go send for each and every one today and tell them everyone will be here. You will see the cheetah will stay away, the true husband will appear. We will see, we will see, we will know who is he. That's just what I'm gonna do. We will find out the truth. I sent for Game, I sent for Ghana, I sent for Palawala, I sent for Kama Soko, and we know who is who. Who
is that?
That's me, old man Gonda. I've come from the farm ever since I've been knocking the door.
Who is that?
That's me, old man Gonda. And I've come from the farm ever since I've been knocking the door. Hey, God, man, I love you, but you too rascal. This time if I catch you, I swear I'm finished with you. The first time I caught you, your boyfriend used to call you Lala. Again I have caught you, now it's a bag of cassava.
Who is that?
That's me, old man Gonda. And I've come from the farm ever since I've been knocking the door.
Who is that?
That's me, old man Gonda. I have come from the farm ever since I've been knocking the door.
Oh, Ghana, I'm coming, morning, Ghana. Hold your heart, let me tell my lover, I'm coming to open the door. Hold your heart, let me tell my lover, I'm coming to open the door.
I say, but man, but what is down there behind the door? I say, but man, but what is down there behind the door? That looks like a bag of cassava. Me, I want to know. The first time I caught you, your boyfriend used to call you Lala. Again I have caught you, now it's a bag of cassava.
Who is that?
That's me, old man Gonda. I have come from the farm ever since I've been knocking the door.
Who is that?
That's me, old man Gonda. I have come from the farm ever since I've been knocking the door. Hey, come man, I love you, but you too rascal. Sweet come man, I love you, but you too rascal. Oh, come man, sweet come man, I love you, but you too rascal. Oh, come man, hey, come man, I love you, but you too rascal. Oh, come man, hey, come man.
Like I said, we do have that's a welcome, and Mr. Koshia is the entrepreneur. We'll give him 1 minute at least to welcome you.
Hello to all. My name is Mr. Abulai Koshia. I'm from Liberia. Came here as a refugee, and today we are very, very happy that we're here and having to be in the middle of all of you guys who actually want to go to Liberia, my country that you're going to serve. So whatever activity that you guys are going to initiate, I am a recipient of your offer. So I thank you guys, and I'm happy to receive you at my restaurant. And you're always welcome to be here.
Thank you.
Thank you.
I serve Southwest, the African and Caribbean around here. Been in this for more than almost 2 decades now. So he just came from Liberia like 4 days ago. He was on a mission to Liberia as well. So thank you, Mr. Jabate, for coming. Like our young brother, so the Liberia Medical Mission, basically our focus going forward, the scope of our operation is not limited to Liberia only. So as a result of Ebola, we decided at least to extend our operation to either Sierra Leone, Guinea, and Ivory Coast, the neighboring countries. Okay, but for now, because of our limited resources, we are now doing Liberia, and from there we can extend it to other countries. Even maybe as time goes by, since we have some of our colleagues that go to Haiti, we will have resources at least to volunteer, to go to Haiti when the need arises. So I just want to, say that to my, to my brother. So, and I also want to take this time to thank all the volunteers that took part in the mission in 2011, 2013, 2016, and now we are preparing for 2018. Okay, so I was hoping that, even if we can't come up with a date today, but I'm hoping that we can we'll come up with an official date for next year, and that will actually depend on our provider, the availability of our providers. Okay, so because there's a certain time in the year that is very difficult for you to get providers to go with you. All right, so since we are in the setting, normally we usually go sometime in March, going to April, and sometime February, going to March. All right, so we have alternated between those 2 months. Okay, so depending on the scope of operation that we will carry on next year, and we want next year, make sure to be one of the biggest, because we want to actually extend the operation to not only Monrovia, but we will also want to see whether we can extend to other rural areas. Okay, so in that case, then we will need a lot of resources going into next year's operation. So, I don't know whether we can, from all of our friends here, do you think of a month of next year, a tentative month that will be like suitable month for the providers? Because I know they are starting time. You cannot even go to any provider, they will tell you, no. This month is not a good month. All right. So what you guys think of, is there any time during the course of the year that you think, hey, this is a no-no, or, kind of a flexible, yes?
One thing we have to keep in mind when we're finding a date is also the season. Because in Liberia, when it's raining, they really mean it's raining. So we always like to go during the dry season.
Yes, exactly.
So that our patient will be standing in line in the heavy rainpour in Liberia, which will also inconvenience us from doing what we need to do. So we normally go anywhere between between February and April for that reason. So please keep that in mind when picking a date. It's our patient, because the first time we went, we missed the rain season by 2 days. Our last 2 days was nothing but pour down rain, patients in the rain, and we decided this is not going to work for our patients. So yeah, let's keep that in mind.
Thank you for that. Generally, we usually go for like 2 weeks.
2 weeks.
So
And we also go like part of 1 month, and even January will even be better because it wouldn't be as hot as it is in March.
Yeah, exactly.
So, and keep that in mind when we say hot, we really mean hot.
okay. So probably we can probably look at, we're not just going to maybe come out for tentative between January, end of January, February.
I mean, people can email us
Yes,
the date
so-
that will work for them.
Exactly.
And
So,
then we can read it just the same,
Especially
sit and
the
decide
providers.
between those days. Yes.
Well, Joe,
Yes.
based on the history of the three missions that we've had and the discussion here, so is it even going home for people? Most likely, it's gonna be between January and the first week of April. I mean, that's a 2.5 month or 3 month span.
Right.
So you don't need to worry about the rest of the year. People can look at their January to the first week of April schedule.
Right. Right. And the majority of rural especially. And the provider will pretty much be the driving factor. Because, I mean, without you guys, we don't have a trip. So your dates is what you draft the date, finalize the date. So if you guys can give us between January and the first week of April, your availability, then we can all meet and discuss the finalized date.
yeah.
And it's not something you have to do today.
Yeah, so basically we can also set up email, but I just wanted to have in mind that we have between January and, and first week in April, so we have to at least do the mission within that time. I totally forgot that we had some of our colleagues that wanted to dial in from Liberia. I totally forgot. I know they will get mad. And there are some of our colleagues that are calling from California, and Minnesota and Atlanta. But I totally forgot. I know probably they might have been on the. But anyway, I'll just put it on in case.
You will be the first person to join the meeting. The line will be silent until another person joins.
Okay. So all right. So what we're going to start is that based on the different things that we intend to do. I know my colleague, our dear friend, Kaliba was with us last year. He went on an assessment form to go and assess the prostate cases and probably we're also going to hear from him and just any plan for next year and what are some of the things that he intends to do, and maybe going forward then we'll come up with a comprehensive work plan to see what we intend to do, what actually we will do, so that will define the mission objective, and we will communicate that with our colleagues with the Ministry of Health, and we'll also communicate that with the local hospitals and our local coordinating committee on the ground. So, Dr. Bell. And by the way, he was named as Dr. Kova, which is Chief Kova from Alofa County. So that was a gowning ceremony for him while we were on the mission. So in Liberia, he's called Chief Kova.
It was a real pleasure to get to go over there with you guys last year. So I was there for about 4 or 5 days last year in the clinic with these folks, getting a chance to talk to some of the people about essentially prostate and urinary health. And it seems like there's a dearth of any kind of treatments over there for guys with urinary retention, BPH, those kind of things. And so rather than here where they're relatively simple problems, people get medications and oftentimes that takes care of the problem, there's a lack of medications, lack of any kind of surgical therapies, and lack of any kind of follow-up. So a lot of these guys were either getting long-term suprapubic tubes that were there for life, or they were in the hospital with kidney issues and retention and failure due to prostate issues that we would think of as simple to treat. So again, it seems like there's a big need for it over there. I think the question, Joe, that we're going to have to address going into next year is what our capabilities are. So again, to get the surgical stuff off the ground is going to be a pretty big undertaking. So we'll need to, one, identify a patient population in need. 2, we'll have to figure out, do we have, 1, the equipment over there, and 2, if not, how much, compared to everything else, we're willing to, either the government or, I can certainly get some of the disposables, but, the basic things we would need over there in terms of scopes, equipment, supplies, OR stuff, in terms of how much we can coordinate there. And then one of the big issues last year was Liberia had actually lost their last urologist. Their last urologist had died about 2 weeks before we got over there. So while some of the surgical folks over there are pretty interested in taking on and providing urologic care to these people, we'll have to figure out, if we're going to go over there and do surgeries, especially bigger procedures, prostate surgeries, things where there are complications, bleeding, other issues, are we going to be able to do it safely? So can we, 1, get people through the OR easily, and 2, if we can do it safely, are they going to have follow-up? So are we going to have providers on the ground that if they do have complications, issues, problems, you know, are they going to be able to be watched and followed and making sure that we identify them and care for them? So again, something we can certainly shoot for. We've got a year's worth of time to try to coordinate some of that, but especially you and I, and then some of the folks over in Liberia, I think we'll have to put our heads together on, you know, one, what's realistic now, you know, and again, not necessarily jump straight into these, but if we can do some of it now and get it set up for next year, perfect. And if not, how are we going to continue to build in the years going forward to make sure that we can do it and do it safely and build a good project? But I think once we can, you know, there's a ton of interest from urologists either within our system and outside that would love to help in some of this. So it's from a manpower issue here, we got plenty of support. It's just a matter of making sure we get all the pieces in place.
What hospital are you based in?
So I'm at Penn.
No, I mean Liberia. Where
so-
were you doing this work?
so
JFK?
So JFK, I think,
Okay, because you need
yeah.
to centralize in the beginning.
Yeah,
Right.
we met the surgical team there,
Right.
and
Yeah,
some of the
they're great. I did
residents,
too,
and
yeah.
there's certainly interest. But right
Yeah.
now,
Yeah.
they can perform open suprapubic prostatectomies, which is good. But we don't have the equipment for anything like a TURP or any of the endoscopic stuff, which again, most of the folks over there would probably benefit from without having to go through a big operation. So, and to get most of that in place wouldn't take all that much, you know, between Bovie machines and supplies. But you know, the big limitation factors right now are things like clean irrigation fluids, you know, having the basic post-operative medications. Most of the smaller prostates you wouldn't need anything like blood for, but for bigger operations you may. So again, just even the stuff that we consider simple here, we would there's a lot of moving parts to say, okay, we would need this, this, and this, and can we have that there in place, and then can we follow up on it?
Excuse me. Did you see? Did you do an assessment of?
Yeah,
were there a lot of?
A fair amount. Again, we didn't have it set. I know last year I had jumped in with a few weeks before, so I didn't. We didn't have a ton of it set up. But even in that time, in each of the clinics, we probably saw 10, 15, 20, people that had some sort of prostate issues, problems, if not more, of which probably 5 or 10 of them were totally tube dependent, young guys. So.
Because the need is really, really great.
Yeah, it sounds.
So many people who need that help.
Yeah, it seemed like there would be, if we started looking for it early and identifying those people, it seemed like there would be a very large number.
Yeah.
There's no minimally invasive way to do it. Being an interventional radiologist, I'm thinking, is there something that you could bring?
There's newer stuff that's coming out
But
that
it's
also
new.
it's new. It's not
Yeah.
well tested and
Yeah.
it's expensive.
Yeah, just
and-
thinking it's a machine you could afford to be carried.
Yeah. Unfortunately, most of the stuff that does it now is that there's a ton of disposables that go with them too, so that
Yeah.
most of the companies can charge for it. So again, the tried and true and simplest way to do it would be something like a TURP, just because it's cheaper.
Exactly.
But
That's true.
and it would benefit a ton of folks. And once they had the basics on the ground, it would just be a matter of bringing disposables over every year.
Might be worth looking into what the resources are at like Tapeta, because I feel like Tapeta Hospital, even though it's in the middle of nowhere, has a lot more resources. And they also have more surgeons there in terms of like what you might be able to do there, and Redemption as well, just because those are really public hospitals, and I think somehow their blood bank situation is different. There's a lot of differences between the hospitals, like Redemption and JFK, even though they're in the same area.
I think we stopped at Redemption last year.
Capita.
We did. Yeah.
We didn't go.
We went to Phoebe.
Yeah. Went to
The
talk.
Phoebe is
No, we
like
did not. We did not go to
running a
Phoebe.
hot-
We did not
Phoebe
go.
doesn't have any general surgeons right now.
they don't?
They have OBs, but they don't have any general surgeons.
No, they don't.
The other thought I had is all of the surgical residents, all of the medicine and surgical residents all need to do a research project to graduate. So like some of these are like low-lying fruits for quick research projects that they could even not necessarily publish in big journals in the US, but like the African Medical Journal. So when you think about projects that you're doing, especially if you're like collecting a number of patients and identifying that might be something you could turn into a research project, because they also just lack the mentors for research there too.
And we longitudinally over time, bringing some of them over here for a period of time to work with some of our urologists and see some of the stuff we do so that we could have a
The problem with doing
collaboration.
that is like getting them like
It's
allowing, like we have a lot of
challenging.
like shadowers in the
Correct.
ED, and they're literally allowed to watch what I do and never allowed to touch the patient.
Same with
Show them
you.
how to do it, yeah.
Training programs they have?
So the
Residencies?
residency programs, there's a pediatric program, an OBGYN program, a surgical program, internal medicine, and that's it. There's no radiology program currently. And they rotate mainly at 3 different hospitals, so at Redemption Hospital, Phoebe Hospital, Tapeta, and JFK. And not all of the programs go to all of those hospitals. And the residency programs are generally pretty small. So in pediatrics, I think there's a total of 10 residents. In surgery, there's probably a total of 10 residents across the board. And it's interesting that the medicine and surgical residents who are at the end of their training have actually been in training forever. Like, they're probably in their mid to late 40s because their training was interrupted so many times by war and Ebola, and whereas the newer residents are like in their mid 20s. So there's a big range of like how much experience those residents have and what they can do. And I think right now they're going to run into a problem if they're very experienced residents who are about to graduate, but then their less experienced residents really have much less experience. So.
Him is my cousin, I think, excuse me, he was saying on Clear Street because he has a prostate. He went first to Ghana to say surgery. I think that the program had told him that he needed just a tablet. Fortunately for him, when he came here, he was in Detroit, and that's all they did. Now he's just on medication. There's no surgery, but he has to come at least every 6 months here for the doctor to see that kind of thing. But I told him, I said, well, the doctor will saw you. He works in different hospital there. His brother told him, come to Detroit, and he went there, fortunately. I was trying to get him when we were coming here, but I lost him, so I don't know where he is. So
the quick question.
My chairman, Pastor Darji, has a great story. He's Ethiopian, and I've been to Ethiopia, I've done some of my work there, but he just, in a 100 million country, with 70% being young, they've just graduated through CHOP and Addis Ababa, Black Lion, the first 2 pediatric radiologists in the country. And now they're going to sustain themselves by having a program that they're training. So much akin to a TERP, training a couple of key players who train each other, rather than going for the mission every 3 years and coming back and waiting 3 more. That would be the indelible mark for any of us to leave, is to train in our respective areas. And identify players that come here and observe. If they have to observe, that's what they do in our world. In
radiology is probably a little easier, right?
You observe, that is easier, yeah. But in some capacity, they get their hands dirty here maybe and learn on the site. So TERPs, that would be very great if that were possible.
Okay. So the question now is that, what I would suggest to you is that since you said that there may be some of your colleagues who likely, be interested in going with you, is to give us, based on your assessment, what can we do? What are the and now, once we start the planning process now, then maybe it will be a periodic meeting where colleagues from JFK will be dialing in. At least that will give you idea of what they think, and we can begin to at least identify patient population, and they can also start screening and stuff like that. So by the time we get there, at least that we have an idea, what are these, what kind of patient population you have, and what we need to do if, because you saw in Liberia that basically there was no equipment.
So why don't we at least start with this? How about you and I will be in contact over the next couple weeks, and I'll make you a list of what I would foresee as what we would need to have in place to start even doing surgeries there. And then we'll get in touch with I'll have you touch base with the folks over there at the hospital and see what of that is realistic to get within the next year, either from trying to get it there or trying for us to get it here to bring over there. And then within the next 3 to 4 months, we'll have to decide, is that going to be realistic to do by 2018?
Right.
And if it is, then we'll start working on, okay, how do we screen these patients? Who do we get? Who are going to be the people that we're going to target? And if it's not, then we talk about, okay, what do we want to put the rest of our efforts in first, with the idea that, okay, for the next mission, maybe we'll shoot over that time with collecting the equipment, the training, the people, identifying the players. But I think if we're going to do it, we'll probably have to make a determination within the next 6 months or so, at latest, on is this a realistic thing. So let me at least come up first with an idea of what we would need, and then you guys say, how much of it can be done.
Well, I think jumping the gun, Veronica's probably going to be
Mm-hmm.
a big asset
Yeah,
to you,
I
as she
agree.
can access some of the stuff here.
And maybe we can include her too to see,
Yeah, absolutely.
you know, because I know there's a ton of waste here.
Right.
And I work with the urology folks, she works with the surgery folks. Maybe we can get some of the people here at our respective hospitals to see, okay, how much of that stuff can we come up with? Are there old bipolar machines? Are there old cameras? Are there old things that they're going to replace anyway that are still good and still useful that we can take over with us? And we could also potentially reach out to some of the urology offices and folks around the area, you know, to see what else they would have. Because again, most of the stuff doesn't have to be perfect to do it. It just needs to be functional.
Absolutely, absolutely, absolutely. Yes, and I think Anne and you know Alex has touched on you had also stressed on that while you're in Liberia, because the only urologist that was in the country had passed away before we even got there, and so the issue of training was highly emphasized while we're there, because you saw some of the residents express interest that, hey, we don't have urologists, all right, in the entire country. So basically, I think what we need to do is that while we are doing that planning, we need to come up with some kind of a strategy, how best we can set up a program for some of these residents, either via video conferencing, some sort of training that we can back upon while we're there. Because like I said, the mission is good. Go and see a few cases to save those lives. I mean, it's very important, but also more important is to provide the resources, at least local physicians that will be doing the work. Because if we can go 2 years, then what happened to the other cases that come, after that? So that's why the issue of training, we need to at least emphasize the issue of training. Okay, I know it may not be 1 year, it may not be 2 years, but we need to actually look at something to begin training local physicians as well. Even if it's that one person, let the entire country, the 4 million people say, okay, yeah, we have one urologist, that we can at least, have some hope that if someone in Tapeta or someone about 800 miles away in another part of Liberia, who's having prostate cases, prostate issue that they can travel at least 3 or 4 days to come and see this one urologist to say, okay, yeah, what's my fate? So I think that's also another thing that I want you to look at, along with your colleagues, to see, how best we can do in that area as well.
Is there a way to develop a collaboration with a country like Ghana? Because obviously it's hard to train on the ground here and touch patients. I mean, it'd be lovely if you could have that collaboration. But if you could have a collaboration where you have limited training in a place like Ghana, is that possible, or the same barriers exist to move around
I think if you
West African
coordinate with because all of the residency programs in Liberia are run through the one organization, the Liberian College of Medical and Surgeons. Like, you can touch base with them beforehand and let them know that you're coming, and they can put you in charge with the residency directors for each program. And you could probably coordinate to get the year 3s or year 4s. Like, I think it's a 5-year program. You can get them to come with you, or at least know that these are the people who are going to be rotating at whatever hospital that you're at, and have them at your disposition, and make sure that in each case that you have at least one resident, if not 2. Because they're going to do the surgeries anyway. They're doing them. They just don't know how. I've seen them do incredibly complex surgeries just because they're like, well, I looked it up in a book and this is what I did, because your options are so limited.
So that's right. So video teaching, like a YouTube format.
And that's easy to do in terms of TERPs and a lot of urologic stuff. The tough thing we run into is with no urologic training over there. There's a sort of a big difference in terms of endoscopy between surgical training and urology training. So they oftentimes lack the basic endoscopy skills just because they don't do as much of it to do a higher level thing like a TERP. So they, getting them to, again, I can have them watch it a bunch of times, but we got to find a way to get their
hands dirty, which would be in Liberia.
But I'm confident there was a way to do it. I was over in Vietnam a few years ago, and with the folks from Orange County, they had the biggest, Vietnamese population outside of Vietnam. So they actually identified a person from Saigon to come over to them, work with them for 3 months, and then they went back, once or so a year with the idea that we're going to train not only him but the people around, but we're going to focus on this one individual to to make sure that, okay, this time we're gonna go over X number of cases, then the next time we go over, whatever wherever he's at next, we're gonna identify and do those kind of cases. And then we'll bring him back every once in a while with the idea that, if we need to show him more stuff and do more stuff. So it's a workable system, it's just a matter of identifying maybe 1 to 2 key individuals that we really have an interest in and want to do it.
It's been done in orthopedics. Dave speak about
Yeah,
had Nepalese people come. I don't know if they got their hands dirty, but we should check. Because if they did, they're now the orthopedic surgeons in the country. So it's already.
I think what I would suggest in that area, so it will be our colleagues from Hospital University of Pennsylvania and CHOP. Alex she's been going to Liberia for, she knows the how the system works in terms of the residence program. We get Alex also involved along with some of our team members to kind of coordinate, and I'm also going to get the president of the residency program involved, so that when we're doing this periodic program, then they can dial in, at least 1 or 2 persons can dial in to our meeting as well, so that we can do.
Who you need to contact more is the president of the Liberia Medical and Dental Association, who's my classmate, so we can list with her, to people because she's a very hard working person.
Yeah.
What are the other immediate needs besides urology? It seems like there is a big need for that. What other areas you guys sense that there is a big need?
Radiology.
Well, could I just before we get, so I think it's a good question. My answer to that is, if you can think of an area of medicine, it's an area of big need. Period. There's no doctors in the country.
I'm thinking more infectious disease, I'm thinking chronic disease, cancer, diabetes. What are the big needs for everything?
I guess what I wouldn't, I know as Joe and I've had many of these conversations, off of Dr. Caleb's comments and everyone else's, I think that Joe, you and leadership, as always, take thought, feedback, input, discussion from today, but to me it's always really critical to really define what the strategic focus is here. Because it could be anything, and it is very easy to go in about 90 directions at a 2% level. You don't feel good about it, you don't accomplish much. Are you trying to be acute, immediate interventionist, or are you trying to build long-term capacity? Are you trying to build any capacity, or are you just trying to go in and do 100 surgeries and come home? And so I think I think any strategic plan could have both. We're going with a specific objective in terms of what we're going to accomplish on the ground in immediate care, while we build peripherally or tangentially off of that to expand that over the years as you talk about training and residents and more advanced surgeries and things like that. But I think, so in 2011 there was no urology focus. In 2013 there was no urology focus. In 2016 Dr. Caleb came for a few days. So focus on driving things. What can this mission do? What's the strategy of this mission, near term and long term, so those can be integrated. And then I think to be specific, and I would err on the side of being more narrow in what the objectives are. It's easy to be broad, again, because there isn't anything I can think of from A to Z that is not a humanitarian catastrophic need. And so, but we had difficult times in the past just in general medicine clinics with adults and pediatrics. Didn't have the capacity, didn't have the resources, didn't have the right medications. And so, are you going to do pediatrics or not? Then you need to have the capacity and resources, the right medicines, et cetera, to do that. Adults, if Dr. Cable will lead a strategic piece on urology, fabulous, as he was talking about, then really define, here's what I think the capacity could be if I had a urologist coming for 7 to 10 days, near term for that mission. And then here's what I think we can use that to continue to build mission after mission, or with training and so forth. So I think it's really easy to go off and get into about 100 areas. And I think that's the downside, that's the trap. And so I think it's can we go over there and do 3 things or 4 things really, really well for those 2 weeks and build something each time for those 3, 4, 5 things each time? Because everything is a need. And a team of, and I don't know what the team size was last year, I don't recall, but it's a team of what? 12, 15, 20 people going? And so we're gonna go deal with peds, adult general medicine, radiology, urology. So each of those pieces, as you bring that provider team together, if Dr. Caleb's gonna drive that urology piece, beautiful. Got a radiology piece, beautiful. We're gonna drive a pediatric general healthcare piece, beautiful. And if there's an adult outpatient clinic kind of thing, there's your 4 pieces. Can we even really resource and staff those effectively to go over, and so that the providers going and the whole team going feel really good about what's being done, that we're ready to do it, we've got the things we need to do what we agreed we would do this mission, and then build that for the future as well. And that impact then transcends to the communities there too. So having rambled all of that, I'll shut up. But for Joe and I, for like the last 4 or 5 or 6 years, we talk about this whole, we gotta, I could throw a new specialist of a doctor on a plane every year and go over and try to do something. But what we've done by the time I die is I've been on 27 missions with 37 medical specialties, and we treated somebody every time. And maybe we do. If you want some sustainability and so forth, and that's really strategy.
So, and I think that's a really important point. And I'm so sorry, we've got to run here in just a minute, so I'll leave. I think that's also one of my concerns, is that we have to identify surgical training and surgical, even, what, if we're going to invest in a limited amount of stuff over there, is that, the one thing you want to put a lot of money and time and resources in, because treating one surgical patient is probably significantly more financially expensive than treating a bunch of people in terms of medicines and medications and shorter things. So I totally agree. We can do the urology and we can invest and build in it, but the question is, with the limited resources we have now, is that the focus of where you want to put it? And if so, I think we'll have people to do it. But if not, and you say, hey, that, maybe we'll come back to it at some point, that's reasonable too. And we're happy to be a part of either of it. I think it just comes down to what you want to eventually go forward and build, and what the focus of the next trip or the next few trips will be, and how you want to incorporate that. But again, it was so nice to see everybody. Thank you so much for having us, and Joe will be in touch over the next week or two.
The lowest hanging fruit is, in terms of immediate impact on Liberia, but have you sense, like you were asking, what is low hanging fruit to start?
Well, like Tom said, honestly, when it comes to Liberia, you have been there, but when it comes to Liberia, everything is considered as low-hanging, but I think we need to really put a lot of emphasis in the area of training local physicians. I think that will be the key.
I would say nurses too.
Huh?
Building local capacity.
Yes, building local capacity, whether physicians, whether nurses and all of these stuff, even down to biomedical engineers, because this is where, you and I talked about it, and that's what our biomedical engineer person, so for next year's mission, because you have seen a lot of equipment, there's, taking dust at the various hospitals. And so one of the things that we want to look at is that tap into some of the resources, the biomedical engineering resources at CHOP and also at HOP, so that they can beef up. Our guy can actually lead that mission to go and begin to train some of our local folks how to repair, EKG and all of this stuff. Because some of the things that we even donated, we went to a hospital, a little clinic in Bassa. An incubator was donated, by Germany or Britain. It is there. My friend looked and said, look, they have been waiting for an expert to come, and they got told. Yeah, he said, well, this one it doesn't even take quite 1 or 2 minutes to repair this one, and now they're waiting for an expert to come from out of country just to come and fix that. So therefore, the issue of training, especially biomedical engineer, to train some of those folks so that at least I don't be running here and there to begin to, to work, look at those equipment. Because if you don't have the equipment, radiological equipment, you can't, there's nothing you can do.
And one of the problems I identified, they have a brand new single plane machine that's shiny and white and new, and it just doesn't work, probably because it's shorted out. I mean, because of the electrical fluxes, the ultrasound machine had also shorted out. So I don't know, generator problems, obviously that's huge. All the equipment is just.
Electricity is out 37% of the time.
And then it's overdoing it, and it's shorting out the other time, the rest of the time. Like the radiology, there's beautiful equipment there, they can't use it. And they want to, and the surgeons particularly want me to train them, but it's just not operational. So electricity and biomedical, a combination, how you make it stable, whether that's some sort of transformer in radiology that needs funding. I don't know how that works, but
they have fun to try and better these things, but they just shoot them.
I don't know what you.
Yeah. I love the emphasis on training. How do you identify the people on the ground who would best benefit?
That's a very good question. I think when we went there last year, in terms of the folks that were interested in neurology, we went to JFK, met with some of the residents, and also the president of the Liberia Medical Association. There were about 5 to 10 people that came straight forward to Khalid and said, look, I will be interested. And we also, what we're going to do is that in terms of biomedical engineering, we want to probably interface with the University of Liberia, probably the electrical engineering department, to begin to identify some of the folks from there, or some other individuals that are technicians that are in them to say, well, hey, can you do the basic training in those areas? So there are people that we can actually work with to identify individuals that are interested. We have probably more than 3, 4, or 5 nursing schools, or more than that, in Liberia. We can identify 3 main nursing schools to say, okay, next year, we identify some nursing educators to say, okay, you're going to go to Fiji, or 2 persons will go to Fiji. During that time, all right, that 2 weeks, here's what we're going to be focusing on, and here's what we're going to be focusing on, and in terms of, a little bit of practical aspect, and also training and a workshop and stuff like that. We can begin at least to train some of those individuals. Yes, but the issue of identifying individuals that are interested, I don't think we have a problem with that, because we have people on the ground that can easily identify interested individuals.
They must be accountable once you train them.
Yes, absolutely, absolutely.
And that's they can head off to Ghana or somewhere else with their expertise.
Yes, exactly.
Ghana needs it too. It's when they come to the United States, that's an issue.
Or coming to me, but I'm just, it's having.
So the issue of, and that's very important. Once we come, you identify and train some of these individuals, all right, and once they find out also. And that's been one of the major issues in Liberia. Okay, if the government is not, if the government is not paying, and they have gotten that, and that was one of the major complaints that I had when I went last year. The University of the Medical College, the dean of the medical college was telling me, hey, Joe, one of the biggest problem here is that we have all that tremendous pressure to produce X amount of physicians just to cope up with the number of individuals in the country. All right. But here's the problem. Once we produce these physicians, and they have been, they are trained, and the taxpayers of Liberia, poor taxpayers of Liberia, their money is being used at least to train these doctors. So when they are trained, then you have one minister who is related to that one. That person gets a scholarship and go to China or go to Germany. Then the person gets well educated. Okay, the person doesn't go back again. So there's a shortage. Yeah. All right. So my responsibility is that, hey, listen. What can we do to incentivize these people at least to remain? Yes. Okay, so that's become a real issue. But in the interim, what we can do is that begin at least to do the best we can. Like, hey, this is our long-term strategy. We train as many people as possible, so that in the cases that we're going to do while we're there, the few cases that we're going to do, we will pair the local physician with our physicians, so that they can also learn. And when we leave from there, there should be other people that can, continue the service while we're not there. But that's been the biggest problem. That maintaining and getting these new at least to stay with the expertise one of the major challenges in Liberia. So,
are there any NGOs they can be funneled through? Because in talking to some of the physicians there, the NGOs pay better, and they're still there for that reason. They're not there because they're paid by the Liberian government. Are there any NGOs we can partner with on the biomedical? I mean, that's the huge. That is really the key to get biomedical. You can't work on equipment that doesn't work,
right.
and that's big, huge. We know that at JFK. That's the biggest thing I have. Nothing works. So that's low-hanging fruit. It's just, I know personally one of my biomedical people who's interested, Zach.
Okay, Zach.
Who would go to Liberia.
Okay.
Again, and he works all over the hospitals.
Yes.
So you could get people to go. It's how you.
That's probably you could get somebody to come here and train too.
That's better. If they could have
John probably
here.
doesn't care if it shuts the equipment, they just care.
Yes, you probably can bring people to
Yeah.
No, but I think there would be an opportunity to get them to train in radiology and cardiology and that.
Because that's actually been, I've worked in a number of countries in Africa and South America and everywhere. It's just everybody generously donates all their secondhand equipment, but it just breaks. Like they plug it into 240 and it's 120 and it blows up. And I think that would be like, that is a thing that is not being done, that a gap that needs to be filled, and that it doesn't matter if you're there for 1 week of a year. If you go for 1 week of a year and you fix all that equipment, you just go back a year later and you fix it again. But if you could train somebody over those times and bring them here, and then make that your long-term sustainable contribution.
I work with the people from clinical engineering. That's part of the peri-op services, the people that runs the ORs. We usually have people from clinical engineering that fix all the machines and any issues that they have, like sterilizers or any machines that are around the hospitals. So I could touch base with them to see if they're interested in joining in and maybe going 1 week. I will have to know what type of machines are being broken so I can know if that's one of their skills.
Get that to radiology.
But if it's that, because they work everywhere, maybe I can convince one of them to join us for the mission.
Okay. One thing that we could do is that before the mission, we'll call JFK, the radiology, and Alex, and Marie can. Yes.
Everywhere in the hospital.
So
we just have a medical student go and take pictures of all the broken incubators,
right.
all the broken stat monitors.
I can do some work for you in June.
Right. So Anne Marie will be going to Liberia in June. So while she's there, she can just take a quick inventory of things that are need to be worked on and
or anything you want.
Yes. Yeah. Maybe a list of things that need to be. So on the way back, then at least we can, some of the team, the model, and all of these stuff, so that at least know exactly what's going on, and we can begin to work on those equipment. So that's a very good something. But again, training. That should be, that's a key. So we're going, if we're going to do, let's identify probably 1 or 2 or 3 things that maybe, for next year's mission, generally we usually do outpatient, which is huge. Again, we want to do, if there are, maybe, I know Veronica will also be, what can we do in the area of hernia repair, and which is a huge something now among the young people. There's so many people that are complaining in the rural areas and even in Monrovia. I got a call the last time that the population of people that need hernia repair is actually growing. I don't know why, but that's the information that I got. All right, and for some reason, and some of them been having this thing for years and years and years, and it's been bothering them, and some of them are not working and they cannot afford the $1,200 or $1,500 or $2,000 to do the something, so they have no hope. But just to remain with that problem until just wait for cost time or whatever the case may be. All right. So maybe we hear from Veronica, but from the outpatient perspective, then maybe Tom, Tom will also make what specifically from your perspective.
No, I think again, because if you just get into the traditional, you name the country, you name the organization, whereas having a mission off to someplace. If it's a general population thing, it's everything under the sky, right? From skin issues to heart issues to aches and pains to neurological issues to bone issues to viruses and bacterias and infections and so forth. And so I think, again, it's not going to be solved today, but I think the things to think through are, again, just at least from my view, it's back to let's really do something more narrow and do it thoroughly, do it well, perhaps use that to build and integrate training to it rather than say, well, we got these 29 medications donated, so we'll go over and do what we can with those. And that's generally a problem for the local community and it's a problem for the providers. So I think certainly define, if we're doing general outpatient medicine, are we going to do adult health care and pediatric health care? Obviously, the communities are going to demand that, but point is, you need to then, between now and that mission, make sure we have the capacity to do that, staff-wise, medication-wise, etc. So in the 2013 mission, we saw hundreds and hundreds and hundreds of children. We had no medications to do anything for what they needed. It's just not, it's frustrating to the people coming and so forth. And so do you start and say, this is what, even if it's based on the provider, this is what we think we have the capacity to do. This is what the top 4 or 5 medical issues are in a general medicine focus in Liberia. And so we will spend the next year staffing, resourcing, and supplying our mission with the needs to carry that out. That means we need to go to the manufacturers or to the people like Brother and Brother and who donate meds and stuff and say, we don't just want what Brother and Brother has to give us. That's not strategic to our mission. Are we doing in adults? Are we doing hypertension? Are we doing this? Are we doing this? Are we doing this? Okay, what are we going to focus on in peds? We can't be all things to all people. It's just too much. And so I think that's an important thing. Again, just like the urology piece. So if there's a urology piece and a radiology piece and a mental health piece, and then somewhere weaving through that is, the question of training and building. So if you have a strategic channel in this mission, we need to have a piece of each one of those that says, and this is how urology and radiology and general medicine and mental health are all going to try to begin to, over the next 50 years, begin to build that local capacity and sustainability. It's not going to happen on 1 mission or 10 missions, but we can begin the process and leave that as a legacy to everybody who's coming behind us. So that's my thoughts on the general outpatient thing, is to say it's the same kind of thing. Let's probably narrow it a little bit, and so that means going into the communities, what's announced to the community is we're having a clinic today for adults. The one tomorrow is for children. The one on Thursday is going to focus, and again, maybe it's too simplistic perhaps of an analogy, but you let people know, do you have a skin concern? Do you have this kind of concern? Then you're coming, so that they know why to come, that kind of thing, to try to get it more focused. So that's sort of the thoughts for today. I think there's a lot of table work, a lot of work amongst the team members and stuff to really build that up and say, here's what we think we could do.
And to Tom, go ahead. I say what I'm hearing is that we can't be all things to all people, right? And we have to really try to figure out a way to define our focus as a team, and then also within each sub-discipline. So I think a first step would be kind of figuring out who we are, what impact we want to have, again, to Tom's point. And then amongst our group, there are different sub-disciplines. It might be a good idea to have each discipline kind of focus in on what kind of impact they want to have, as it relates to the things that we identify. Because that might help us a little bit. If we try to do it all together, we'll get lost in it. So if this is your specialty area, this is the impact I want to have, this is the need, and here's how it relates to our strategic focus. So that's pretty much like the general thing that I'm hearing so far. I think it's important that we kind of come up with some type of an action step leading year and deadlines, because things, you know, we always think we have so much time, and before we know it, it's 2 months before and we're panicking. So to have a deadline for, you know, if we're going to identify our needs and identify ways in which to get there, to have some kind of deadline coming up for it.
To reinvent the wheel, maybe at a country level or city level, a need assessment has been done, or it should be done. What are the main priorities for the whole country, for the city? And we try to help with those. We might not be able to, but at least that will be what is guiding our efforts, probably in a better, more productive way. Maybe it has been done, so we should reach out to the people who has that information. And if it hasn't been done, maybe that's our priority. Go next year, bring MPH people, epidemiologists, and build a network that is able to capture that data, so we know in which areas is more needed what. Maybe it's done, I don't know, I'm not familiar enough with the health system.
We've done, I mean, there's been a lot of work in Liberia. Things just fall through the cracks. I'm willing to bet that a needs assessment has in fact been done. We can probably, now we have lots of, you know, lots of people on the ground. And I think it's an excellent place to start. So, you know, I like that idea.
It's not going to be Liberia at this point in time. There's 462 NGOs in Liberia, there's the United Nations, and the situation is what it is. And so 15 to 20 people going in for 10 to 14 days need to really define what it is we'd like to accomplish for that 14 days and or begin to build for some long-term sustainability. You know, that the 25 of us or something can do over the next 10, 15, 20 years, beyond the massive, you know, initiatives that go across the breadth of the country.
Yeah. At this point, we're maybe 6 years in, and we don't want to, what I find happening is we go, we have this huge impact, we leave, and there's nothing in place. So a lot of the themes that have come up has to do with kind of systematic infrastructure that are going to be in place so that we can sustain the work that we're doing. When we're thinking about our focus, I would highly vote for kind of what do we have in place to teach stuff. Like when Carly and I come in, I know we're going to get to mental health at some point. I may have to leave soon. But, you know, what are ways in which we can make sure that someone does the work while we're not there, because we're only there every 2 years. Our hope, even if we were there every year, which is somewhere that we're leading towards, what happens the other 11 months that the Liberia Medical Mission team is not there? So it's important to think about, you know, immediate impact, but certainly our long-term, our presence needs to be felt throughout the year. I'll just put it that way.
Documented. So if we are going to, we have to look at it about that. People with cataract or whatsoever, whether they will have a cataract surgery. And since we have ophthalmologists in Liberia, they can also join us to be the post-op if we leave. So they too have to be involved.
Easily with short-term medical missions, like prostates are probably one of them, though I'd never thought of it before. Like cleft lips, cleft palate, cataracts, like dental things, hernias. Where you fix it once, it's fixed, you solve the problem. The problem with trying to treat like hypertension or diabetes is like those people really need follow-up. And if you're not there for another 2 years, like what if you gave them a medication that's working amazingly for them, but then they can't buy it in the local pharmacy and nobody's going to sell it. So that's, and I feel like even when you get involved in pediatric care, yeah, you can treat that ear infection, but like then you've taken that kid out of their, like even when I see patients in the ER, I sometimes feel like I'm stomping on their general pediatrician's foot, right? Like I see them for one thing and I'm like, oh, well, here's this other problem. I could fix that, but really that's the job of their general pediatrician, but I don't want to stomp on their, like anybody else's foot. And when you steal them into like our medical mission and away from the general practice, like what does that do to the system, how the system works? So I think we need to figure out like how we put ourselves into that system and really ask that system what it is they need. And if we want to do long-term service, finding out from the trainees or the people who work in the hospitals what training they need. I feel like we could also go in and really like teach like CPR, ATLS, like you can teach those things in a week, right? And have people practice those all year long. So, but those are things that you really do need to go in and like quickly, like it takes a week to teach that really well and practice that and go over things. So you have to pick things that you can go in and teach people that they can, and maybe have one person check back every 3 months with them to make sure it's being followed, or pick a topic like prostates, which for half the population is probably a really important thing, and fix that. And that's like you fix that once you're done. Like, but I agree with maintenance is hard if you're only going to be there for short periods of time.
My information, and I thought that maybe we could do hernias, you know, things that I can really fix, because I thought that maybe we could focus on a few things that are bothering them for a long time, but they're actually something easy to fix. The prostate, I don't think is as easy as we're putting it. These patients can get complications like bleeding, you know, things that needs to be followed. I thought hernia sterilization, although I don't know how the female culture is there, but I read that the rate was 6 childs per woman. So I thought maybe doing a little bit of woman health and doing, you know, sterilizations or things like that. That's what I do back home in Venezuela, that we have done missions like that. It will be helpful. But that will have to be assessed by people in ground, you know, to see if that's something that the females will be interested in. But those surgeries are easy, are things that are need almost no recovery, like 24 hours of follow-up or 1 week, and that can be done. But I feel like if we're going to focus on the prostate surgeries, we should leave this for another time, so that way we can concentrate all our, you know, all our thoughts in one surgical mission. I think if we start doing the hernias and the sterilizations and, you know, all of that, it's going to be too much. If you find out that this is not something that is feasible, you know, to do the prostate, because you're going to need a lot of resources, maybe we can focus on doing the hernias and things like that that are easier, you know, to do. They have less time and less resources. I can try to talk to my hospital to see if I can get, you know, the supplies. I mean, I'm going to give you, of course, a bunch of donations and supplies, and that's something standard, but I'm not sure that I'm going to be able to give you everything that you need. So we might have to just ask them for something, you know, just to donate, you know, actively, something that is expensive and that you actually need, and not something that is a waste. So that we can talk further, but if you find out that the prostate doesn't work or is too much, you can let me know and I can try to go through the area of the umbilical hernias. And I think that's something that is definitely needed. When I have done missions, these surgical missions, these little surgeries, nobody can do it because they're elective. So there's something that you wait years to actually get the chance of fixing a hernia or
lymphoma.
Exactly, we can do something very small surgeries like lipomas, and we can do, you know, like a skin. Although those things might need to go to pathology, we will have to have like a pathology in order to make sure that we're not taking any skin cancer that we're not treating. But otherwise,
and I think Ms. Roberta is going to point to that issue, because we're thinking about be mindful of your capacity and then also be mindful of the infrastructure that's already in place. There isn't much of a system in place to begin with. So we're talking about it as if maybe there's something that has a system and we can work within that system. We should just be thinking, man, this is what we have, and how can we make the most impact, and how can we optimize it? So maybe, as they do with other countries that have limited, you know, physicians or nurses, they train local professionals on very subtle things to kind of do different work. And I know specialty areas, we obviously can't do that, but I'm just thinking about our focus has to be geared towards working within our capacity, but understanding that we're not working in ideal situations where there are systems in place to do those
That's
things.
my concern with the prostate, but he will know better than me what is his rate of complications. But what about anesthesia? That was my concern. That's what I was going to bring up for me, because we will need anesthesia people. We will need to see. They have medications.
They have training, no medications, no machines.
They have nurse anesthesia.
But you do not have no anesthesiologist.